സാറേ ഗുഡ് ഈവനിങ്. സാറിന് സൗണ്ട് കേൾക്കുന്നില്ല.
കേൾക്കുന്നില്ലേ? ഗുഡ് ഈവനിങ്.
കേൾക്കുന്നു സാറേ, കേൾക്കുന്നുണ്ട്.
ഗുഡ് ഈവനിങ് കേശവലി സാർ. ഗുഡ് ഈവനിങ്. ഷാനവാസ് സാർ ജോയിൻ ചെയ്തില്ലേ? ഗുഡ് ഈവനിങ്.
Jose.
Good evening, sir. Good evening, sir.
Jose, I have to leave by 9 o'clock and absence in the convocation. 9 o'clock ഞാൻ ഇടയ്ക്ക് ലീവ് ചെയ്യുവേ.
കുഴപ്പമില്ല. താങ്ക് യു, താങ്ക് യു.
റോസ്മേരി
ഷാനവാസ് സാർ വന്നില്ലേ? ഡാലി മാഡം ഗുഡ് ഈവനിങ്. മാഡം മ്യൂട്ടറാണ്. ഷാനവാസ് സാർ ഗുഡ് ഈവനിങ്. ഷാനവാസ് സാർ,
കണക്ഷൻ പ്രോബ്ലം എന്തെങ്കിലും ഉണ്ടോ?
ഇല്ല.
നോക്കിട്ട് ഇപ്പോഴാണ് കയറാൻ പറ്റിയത്. ഒരു പ്രാവശ്യം കയറിയിട്ട് അങ്ങ് പോയി പറ്റി.
ആണല്ലേ? എനിക്ക് തോന്നുന്നില്ല, ഞാൻ ആദ്യം മുതൽ ഉണ്ട്. പക്ഷെ ഒരു പ്രശ്നമില്ല, ഇവിടെ തന്നെ കയറി.
ഞാൻ ഒരു പ്രാവശ്യം കയറിയിട്ട് പിന്നെ ഡിസ്കണക്ട് ആയി. പിന്നെ കയറാൻ പറ്റില്ല. ഞാൻ ഫോണിലാണ് കയറിയത്. മറ്റേ
അല്ല, ഇപ്പൊ ലാപ്ടോപ്പിലായ
ലാപ്ടോപ്പിലൂടെ കണക്ട് ചെയ്തു. ഞാൻ ഫോണിൽ നിന്ന് കയറി. പിന്നെ ഫോണിൽ കേട്ടില്ല.
ബെനോ വന്നില്ലേ?
ബെന്നോ എമർജൻസി എന്തോ ആയതുകൊണ്ട് എന്റെ അടുത്ത് സ്റ്റാർട്ട് ചെയ്യാൻ പറഞ്ഞ സാറേ.
ഓക്കെ. നമുക്ക് സ്റ്റാർട്ട് ചെയ്യാം. ഡിലേ ആക്കണ്ട. അല്ല, പ്രസന്റ് മറ്റേ രേഷ്മ ഇല്ലേ? രേഷ്മ എച്ച്. ശരി. റോസ്മേരി, ഓക്കെ. ഗുഡ് ഈവനിങ്.
ഗുഡ് ഈവനിങ് സർ. എന്റെ നെറ്റ് എന്തോ പ്രശ്നം ഉണ്ടായിരുന്നു തോന്നുന്നു.
ഹോസ്റ്റ് ആക്കിയിട്ട് എസ്കേപ്പ് ആവാൻ ഇരുന്നയാ. റോസ്മേരി നെറ്റ് പ്രശ്നമാണെന്ന് പറയരുത്.
എനിക്കും പ്രശ്നമായിരുന്നു. എന്തൊക്കെ ചെയ്തിട്ടാ ഇപ്പൊ ഒന്ന് റെഡിയാക്കിയത്.
ശരി, ഓക്കെ, തുടങ്ങിക്കോ.
Okay, so today we are cases and patients from Cosmopolitan Hospital. Our second year PG resident is presenting the case. Dr. Reshma. Dr. Reshma.
Ma'am, screen sharing accessibility is not shared.
Yes, present कर रही है Zoom मीटिंग पे. हाँ, बहुत अच्छा केस स्टार्ट हुआ है. हाँ, नहीं, बहुत अच्छा है. पीजी का प्रेजेंटेशन है.
प्रवीण എല്ലാവരും മ്യൂട്ട് ചെയ്യണേ. പ്രവീൺ എല്ലാവരും മ്യൂട്ട് ചെയ്യണേ.
ഇനി അൺമ്യൂട്ട് ചെയ്താൽ മതി. കോ ഹോസ്റ്റ് എല്ലാവരും അൺമ്യൂട്ട് ചെയ്താൽ മതി.
ഷാനവാസ് സാർ സ്റ്റാർട്ട് ചെയ്യും സാറേ. ഷാനവാസ് സാർ.
ഓക്കെ.
അത് കുഴപ്പമില്ല, ഇനി വേണ്ട. കണ്ടിന്യൂ സാർ. അക്കാഡമിക്ക് പോയി, അതിന്റെ ആവശ്യമില്ല സാർ. സ്ഥിരം നടക്കുന്ന.
Okay. So, very good evening to all. So at the outset, I express my thanks to IAP Thiruvananthapuram for giving me this opportunity to chair the session. So we will directly go to the presentation. I invite Dr. Reshma to present the case. Okay. Change to slideshow mode.
Slideshow. Okay.
Good evening, sir. Good evening, all. My name is Reshma. I'm a second year resident from Cosmopolitan Hospital. Today, I'm going to present a case of Vaiga, a 12 years old female child from Pattam. Informant is mother and child. History is reliable. Presenting complaints: dark colored urine for 2 weeks, fever for 1 week, tiredness for 1 week, yellowish discoloration of eye and skin for 1 week. History of present illness: child was apparently all right 2 weeks back when present with illness as dark discoloration of urine, which was acute onset, initially dark yellow in color, gradually progressed to deep red color with no diurnal variations. After 1 week, she developed discoloration of eye and skin, fever, which was initially noticed by mother in her eyes, and later, which was progressed to palms and soles and was associated with progressive tiredness. Fever was of acute onset, moderate grade, intermittent type, with no diurnal variations. It was relieving with antipyretic. It was not associated with chills or rigor. No history of reduced urine output, frothing, facial puffness, generalized swelling or swollen angle, no history of abdominal pain or distension, recurrent vomiting, hematemesis or passage of dark tarry stools or blood in stools, no history of easy bruising, gum bleeds or epistaxis, no history of arthralgia, rashes or joint swellings, no history of night sweats, bone pain, significant loss of weight or appetite. No history of any blood transfusions, no history of limb pain, headache, in ulcers, no history of altered sensorium, seizures, loss of consciousness, no history of loose stools or dysentery, no history of cough, dyspnea, tachypnea or palpitation. Past history: no past history of similar illness. History of hospitalization for pneumonia at the age of 5 years, which was treated with IV antibiotics, and there were no complications. History of travel to Kashmir 1 month back. No history of any long-term drug intake or indigenous medications. No history of blood transfusions in past, no history of contact with non-case of TB, no history of any skeletal abnormalities, no history of any abdominal or cardiac surgeries. Antenatal history: 1 week child of non-consanguineous marriage, spontaneous conception, mother 27 years and father 30 years at the time of conception. Antenatal checkups were regular, iron and folic acid and 2 doses of TT taken, no history of anemia, gestation diabetes mellitus, gestational hypertension, hypothyroidism, fever with rashes or blood transfusions. Natal history: born by full term, normal vaginal delivery, birth weight was 2.8 kg, cried soon after birth, breastfed within half an hour after birth. Postnatal history: no history of NICU admissions, no history of neonatal jaundice or blood transfusion or any other complications. Baby and mother was discharged on postnatal day 3. Developmental history: milestones were attained appropriate for age, is in 6th standard, good scholastic performance and good peer-to-peer interaction. Immunization: fully immunized for age according to national immunization schedule. No acute events following immunization. No optional vaccines taken. Nutritional history: child taking mixed diet, consumption of green leafy vegetables and fruits present. Calorie and protein intake was calculated based on 24 or recall method. A calorie observed was 1580 calorie, expected was 1700. So there is 7% deficit. Protein observed was 26, expected was 30. So there was a deficit of 13%. Family history: first child of non-consanguineous marriage, history of carcinoma breast in maternal grandmother, no history of jaundice or gallstone disease in family, no history of bleeding tendencies, non-hematological disorders, blood transfusions or splenectomy in the family, no history of any non-cases of TB or any other significant medical illness in the family. Socioeconomic history: mother and father studied till graduation. Father is a driver and owns his own car used as taxi, and mother is homemaker, lives in Pakka house, has separate toilets for bedrooms, no overcrowding, belongs to lower middle class family according to modified Kuppuswamy scale 2022. Pet dog at home which is vaccinated. No history of water stagnation near home, no drainage or mosquito rearing areas around home. Summary: 12-year-old girl present with history of acute onset of dark colored urine, fever, tiredness, and yellowish discoloration of skin, with no past history of similar episodes or comorbidities or blood transfusion or significant family history. Developmental milestones achieved normal for age and immunized up to age. General examination: child conscious, oriented, severe pallor and icterus present, No cyanosis, clubbing, lymphadenopathy, edema. Heart rate was 102 per minute. Rhythm regular, high volume, normal character, no radioradial delay, radiofemoral delay. Respiratory rate was 26 per minute. BP was 110/70 mm of Hg in the right upper arm in supine position. SpO2 was 98% in room air. Head to foot examination. Shape and size of head normal. No hemolytic facies. Eyes pallor and jaundice present. Oral cavity. Oral mucosa appears pale. No glossitis or angular stomatitis. No mucosal ulcers or gum bleeds. Neck. No thyroid swellings. Chest and abdomen appear normal. No abdominal distension. No scars or dilated veins. No bone tenderness, no leg ulcers, no skin rashes, petechiae or purpura, no koilonychia or dactylitis. Sexual maturity rating stage 2. Anthropometry, weight for age, observed was 30 kg, expected is 40 kg. So percentile at 10th percentile of IAP growth chart, which was normal. Height for age, 144.5 centimeters observed. Expected was 148 centimeter. Between 25th and 50th percentile, which was normal. BMI 14.3 kilogram per meter square. Expected was 17.4 kilogram per meter square between 5 and 10 percentile, which was also normal. Gastrointestinal examination. Oral mucosa appears.
ഒരു കാര്യം, അതായത് ഡോക്ടർ ഷാനവാസ് മ്യൂട്ടഡ് ആണ്. Unmute ചെയ്തിട്ട് let him talk.
തന്നെ അൺമ്യൂട്ട് ചെയ്യാൻ പറ്റുന്നതാണ് സർ.
ആയിക്കോട്ടെ, ഷാനവാസ് ഒരു മെസ്സേജ് അയച്ചിരിക്കണോ ഇക്കടെ?
സാറ് രണ്ട് ഡിവൈസിൽ നിന്ന് ചെയ്തോണ്ട് വന്ന കൺഫ്യൂഷനാ. അൺമ്യൂട്ട് ചെയ്തോ സാറേ?
ആണോ? അതിന് മാത്രമല്ല, പിന്നെ ഈ കുട്ടിയും രണ്ട് ഡിവൈസിൽ ലോഗിൻ ചെയ്തിട്ടുണ്ടല്ലോ. റിഫ്ലക്ഷൻസ് വരുന്നത്, എക്കോ വരുന്നുണ്ട്.
Okay. So now it's able to talk. Okay. So we'll start with history. We'll finish the history and we'll discuss about history and we'll go to the. That's where we'll usually go. Okay. So after your history, what is your diagnosis? What are things you are considering your history?
After history, my first differential diagnosis is infections.
Okay.
Mainly viral hepatitis, leptospirosis, then malaria, mycoplasma pneumonia. Then next one is hemolytic anemia due to autoimmune causes or secondary causes due to SLE. And my third differential diagnosis is.
I think that's all. These are after your examination and all everything over. So after your history, will you consider mycoplasma pneumonia or like that thing? So what is your diagnosis? What are the primary symptoms child is having?
Dark colored urine, fever, tiredness, and yellowish discoloration of eye and skin.
So everything that can suggest that it is a acute illness, that is fever, jaundice, plus yellowish discoloration of urine. So what is the most common condition you suspect at this juncture in the monsoon? Malaria is not very common nowadays, even though there is so many
leptospirosis.
Okay, leptospirosis. So leptospirosis is the, so you have to rule out one by one, then only you should go to, what are the things in the history for ruling out leptospirosis?
Fever was not associated with chills or rigor.
Okay.
Then there was no significant myalgia.
Okay. So usual symptoms are usually patient will have an acute onset fever with myalgia, bilateral conjunctival congestion. That is the symptom, and we should ask or you should ask or you should then icterus. So depending on the type, so whether it is or the complication, whether it is a Weil's disease or like that, you will have hepatic failure, renal failure, and bleeding, coagulation abdomen. All those you should concentrate. So what is the other important differential diagnosis other than Weil's disease or leptospirosis?
Other infection, viral hepatitis.
Viral hepatitis. Okay, very good. Viral hepatitis. What are the symptoms you should consider when there is a viral hepatitis?
anorexia, nausea,
Okay.
vomiting.
You are considering a viral hepatitis, infectious hepatitis or hepatitis A as the cause. So you should start with fever, anorexia, nausea, vomiting, and other symptoms, and jaundice.
Yes.
Okay, so
Yes.
that those sort of symptoms should also be considered. So what are the other causes or other causes of hepatitis that can be present? What are the causes of jaundice? You know, jaundice.
Yes, sir.
For classification, undergraduate classification.
Classified into indirect and conjugated and unconjugated
It will be
hyperbilirubinemia.
classified into hepatocellular jaundice, hemolytic jaundice, or obstructive jaundice.
Obstructive jaundice.
Of which one will be in your first consideration here?
Hemolytic jaundice.
Hepatocellular jaundice. What are the triad of hemolytic jaundice symptoms?
Hepatosplenomegaly, pallor, and jaundice.
Pallor, jaundice, and
Hepatosplenomegaly.
low colored urine. High colored urine, low colored urine, high colored stool. So all those can be there. Stool may not be there, but hemolytic anemia, there will be pallor, icterus. These are the two symptoms. Splenomegaly is a what? Clinical examination file, not the history. It will not.
Okay, sir.
Okay. So that also you should consider that. So in the hepatocellular jaundice, what are the other causes you can consider? Did you ask about pallor, history of pallor?
Yes, sir, but mother didn't notice that much.
Okay. So after examination, only you are presenting. You should definitely ask. There is whether it is by history there is no pallor. You can highlight, because that pallor, if it is there, you will be diagnosed. Will be very much easy to go like that. Otherwise, it will be a. So you say what are the other causes of hepatitis other than infectious cause in the leptospirosis and other things?
Autoimmune hepatitis.
You can consider autoimmune hepatitis. Then
drug-induced hepatitis.
Drug-induced hepatitis. So did you mention any drugs at any stage of this presentation?
Yes, sir. No, there was no history
of chronic drug administration. You saw it all like that.
Yeah.
So
I mentioned.
Any other way of presentation? But jaundice and drugs.
Jaundice and drugs. Sir, autoimmune hemolytic
anemia also you can consider that one. So also you should consider. Will you consider Wilson for this?
Yes, sir. Actually, autoimmune hemolytic anemia is the first.
So we are not at all thinking of hemolytic anemia at this stage because you don't have any pallor from the history. So after examination only we will be going for hemolytic anemia. So what are the ways Wilson's can manifest? What are the ways that Wilson can manifest?
A neuropsychiatric manifestation.
And we present as acute hepatitis.
Yes, sir.
One of the manifestation of hepatitis, Wilson is hepatitis. Okay. So also you can have pulmonary hepatic failure. Can manifest.
Yes,
then
sir.
other ways, as you said, could be manifest as a what is called?
Neuropsychiatric manifestations.
Not neuropsychiatric. We will be
Hepatitis.
hemolytic anemia. Hemolytic anemia. Severe hemolytic anemia. These are the acute severe hemolytic anemia and acute pulmonary hepatic failure. These are the two emergencies a child can present. Okay. So coming to the history wise, so dark colored urine, fever 1 week, tiredness 1 week, and yellowish discoloration of skin and mucus. Okay. Next slide, please. Okay. So tell us, it was somewhat in the 2 weeks history only, but there is nothing. Why do you ask about no diurnal variation?
Sir, in view of paroxysmal nocturnal hemoglobinuria.
So all those are
Rare, sir, I know it is rare, but I just mentioned that.
But on this paroxysmal, you are not in the history wise, you can't come anywhere with the hemolytic anemia because the pallor is not there. Okay. Then next slide. Okay. So this here child fever started late only. That's a point against your history of hepatitis, infective hepatitis as well. But
Yes.
still you can consider. Okay. Then moderate, intermittent, there is no diurnal variation. I should ask about diurnal variation of fever.
In lymphoma, there is evening rise of temperature. Lymphoma can induce hemolytic anemia or
Always with the hemolytic anemia because we are examination. So what is the type of fever that is in lymphoma?
Epstein fever.
Okay, it's not a evening rise of fever. It is usually a Pellepsin. Classical fever we are
Pellepsin.
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 So next slide, please. Next slide. Okay, now still urine output. Frothing of urine. Why should I ask about frothing?
Nephrotic syndrome, proteinuria.
Okay, so why do you consider proteinuria in a case of pulmonary hepatic failure? Are you justified or you are? Okay, if you want, and you can have Wilson's disease can just
In view of Wales disease.
Wheels can manifest as with proteinuria because
Frothing of SLE also.
SLE. So many conditions can manifest. Okay. Then no history of abdominal pain, distension, recurrent vomiting, and hematemesis. Okay, so that can be abdominal pain can be a manifestation of hepatitis. Okay, all those can be eyes. Easy bruisability. Why should I ask?
Sir, to rule out other bleeding manifestations.
Okay, could be hepatic. You are now still now you are in hepatitis only. So you can ask about one of the manifestations is liver coagulation failure due to liver disease. Why you should ask about arthralgia, rashes, and joint swelling?
Autoimmune disorders. SLE.
So you can have
rheumatoid.
hepatitis B can manifest as all those symptoms. So
Yeah,
hepatitis
yes.
B, you are still in hepatitis B only.
Yes,
The
okay.
problem is you are not highlighting your finding of pallor. That's why you are not going your EDs. Okay.
Tiredness was the only complaint pointing to anemia, sir, at presentation.
Okay, next slide, please. Okay, drug can be a manifestation of hepatitis. Okay, blood transfusion again, this thing. Then, okay, so altered sensory between hepatic encephalopathy or other things. Okay. History, anything else like history? No. Next slide, please. There is nothing in the past history. It was a perfectly normal child. There is nothing in the past history. Okay, next slide, please. So, in the natal history and postnatal history also uneventful. So, neonatal jaundice. So, can there be neonatal jaundice? Very important for you.
Yes, sir. But since it's an acute presentation, but still we can consider it about chronic hemolytic anemias.
Which type of chronic hemolytic?
Chronic hemolytic anemias like hereditary spherocytosis, thalassemia, beta thalassemia major, sickle cell anemia.
Acute jaundice manifestation, acute
Yeah,
manifestation may not be there.
thalassemia.
So you can have intravascular hemolysis as a DD of especially GCSPD, where somebody has already has GCSPD as a diagnosis. So a patient who is having intravascular hemolysis following GCSPD can manifest. For those children have neonatal jaundice also is a manifestation. So you can okay, that is called chronic or intermittent GCSPD deficiency. So what is the sex of the child?
Female child.
Okay,
So, it is present in X-linked recessive trait, but it can also present females to lionization.
Okay,
sometimes.
Okay, so next slide. Next slide. Development milestones are within normal limits. Okay, then immunization. What is the importance of immunization for you as far as here present?
There is hepatitis, immunization against hepatitis A.
So how will you give hepatitis A vaccine? How will you give hepatitis A vaccine? How many doses?
2 doses. 6 months, 1 month and 6.
Okay, 2 doses. 2 doses.
2 doses, 0 and 6 months.
6 months. Okay, 0 and 6 months. What are the types of vaccine available? So GSK is the trade name vaccine. So they will have Avrix is the vaccine that is usually. What is the strength?
Avrix. Okay, sir.
Okay. 720 is the strength that is usually for pediatrics, and also we can have or 1440 is adult dose, 2 doses. So these are sometimes you may ask questions like this one when you are presenting smoothly. Okay, proceed. Next slide. Okay, why do you say percentage deficit? So we usually give how much calorie, how much deficit. That is why usually that is easy to correct the malnutrition. If it is there is 200 calorie deficit is there, you can correct it easily. So your diet protein is also very much deficit. That is not a, what is a routine diet of Kerala?
Calorie deficient.
Calorie deficit. Protein is in fact
protein is
usually high.
excess.
Okay. But here it is low. Okay, we can you have to calculate only. Then we will continue. Okay, you should be very careful when you tell like this. Okay, then family history is a non-consanguineous marriage. Okay, so why can't you draw a family tree, especially after your diagnosis? You are going to put the diagnosis of hemolytic anemia as a diagnosis. You have to draw a family tree also. Okay, that's a your percentage long case family tree is a must, especially you are considering a hemolytic anemia in your as a DD. Okay, so if suppose what is the inheritance of your Wilson's disease?
Autosomal recessive.
Okay, what is the where is the gene?
Sorry, sir.
Gene for it. It's a chromosome and gene. It's a chromosome and gene.
ATP 7B.
Where is A? What is the importance of A?
ATP
7A.
7A, monkey's disease.
Okay, okay. So these types of question may sometimes you ask because once you are answering everything. Okay, very good. Okay, next slide. Next slide. Family history, socioeconomic. So you are primarily dealing with a viral hepatitis, that is infection. Then you are not at all interested in your what is a type of well, house everything is written. But if they are using that boiled cold water like that thing, no stagnation. Okay, Wilson, lepto. Okay, then next. Okay, summary already, sir. So Purushothaman sir, so you want to add? You want to ask?
That is the presentation should be a little bit slow. Very fast you proceeded. Actually, I was expecting Shanavas to be stopping at the end of the history.
I was unable to.
That was your style. Actually, anyway, all the points you have covered. One thing, the few points in this case, I think the basic problem is whether it's a hard finding out there is definitely jaundice, there is definitely pallor, there is definitely urinary discoloration. So which system is predominantly affected? Is it a hemolytic disorder with an intravascular hemolysis? That is one. And the second, is there a liver problem? Maybe there is no liver problem with purely hematological problem. There can be an associated liver problem. There are certain situations, as you discussed there, lysis and liver in a case of Wilson's presenting just like this. It's always a 12-year-old girl. That is a very important, unusual presentation of a connective tissue disorders with a lysis. There is a possibility. So you need to consider the age and sex of the person also. And one very interesting thing, why was the fever not present in the first week? And then your presentation should be including the onset, course, and the progress and the present status. So the little bit of a clarity lacking in the last part. What about the duration of fever, total duration? If the fever is persisting, the longer the duration, the duration is definitely helpful because some points are arguing for, some are against. So that is not a clear thing. So the possibilities in this case, especially the malaria part, intravascular hemolysis, falciparum malaria, why that the fever presented on the after 1 week only is one question. Then the third thing, is there a renal involvement? Is it just a pigmentation of the urine only? In this case, I feel more likely renal is not the the coloration, whether it is yellow or red. That is important. Whether it is bilirubin only, whether it is hemoglobin, whether it is RBC. Because the discoloration RBC hematuria is there, that means renal part also is involved. If it is a bilirubin only or hemoglobin, renal is spared. So we need to, basically it's a between the hemolytic problem or a liver problem. More and more points are for the basic hemolysis because there was no blood loss mentioned but significant pallor. So most likely higher possibility of an intravascular hemolysis producing illness with a long duration fever. Liver is less likely to be involved. Kidney is less likely to be involved. One point in the nutrition point, you should have asked about the intake of milk, raw milk, because brucellosis, we need to consider rarer problems like brucellosis also. And the other thing, the cooking style, what they are using, both the iron deficiency anemia, what was the cooking pot, in the Wilson, copper. So these are the small points I would like to, anyway, well presented. Thank you.
Thank you.
Okay. Anybody else wants to ask any question in the history? Otherwise, we'll proceed. Okay. To the examination. Okay, go to the examination. Change to slide storm.
Sir, can I present?
Continue. Change to slideshow mode and continue presentation.
Make it into slideshow, Reshma.
Okay,
Yeah.
General examination. Child conscious, oriented, severe pallor and icterus present, no cyanosis, clubbing, lymphadenopathy, edema. Heart rate was 102 per minute. Rhythm regular, high volume and normal character. No radial delay or radiofemoral delay. Respiratory rate was 26 per minute.
Okay, we'll go one by one. You will go slide by slide now. So since you are history, so we'll go slide here. So you are saying severe pallor. According to IMNC, how will you demonstrate severe pallor?
Sir, comparing examiner's hand with patient hand, palmar pallor is considered.
So
According to IMNC,
patient hand on your own hand and compare, provided you are not having pallor. Okay, that's number one. So when you say what is which below invert hemoglobin, he will say severe anemia.
severe palmar pallor.
Severe
Palmar
anemia
K is absent.
Severe by hemoglobin level.
Less than 7.
Okay, say less than 7 severe, and whether it is severe less than 5. So what are the conditions where you will have pallor, but there is no anemia? Or you will overdiagnose anemia. Okay, when there is edema, especially nephrotic. A shock is a condition where there is pallor, is there no anemia. Then there is in hypothyroidism and nephrotism, because of the edema, you will feel pallor. They won't be having anemia. So severe icterus, what are the areas you will look for?
Upper sclera.
Okay.
Sublingual mucosa. Palate. Palms and soles.
Okay, so you should tell. You can say severe pallor as evidenced by these areas, that is pale. You can tell. Okay, so patient is having 3 things. Number 1 is pallor. Number 2 is icterus. You have already said high colored urine. So we will consider it as hemolytic anemia now. What is the importance of cyanosis for you now? You are considering cyanosis.
Congestive cardiac failure.
Cyanosis. So PG. Cyanosis.
Sir, sickle cell anemia.
Okay, you can have in a case of your hemolytic anemia, paroxysmal, especially cold hemolytic anemia, you can have acrocyanosis. Even in case of SLE, you can have Raynaud's-like phenomenon. Okay.
Oh, okay, sir.
Okay, then heart rate is on auto, it is on tachycardia is there. Okay, so for high volume pulse, then if you see the, you can send when there is a high volume pulse, you can tell, especially severe anemia, collapsing, non-collapsing also, you can tell them. Okay, respiratory rate is 26. So what is the significance of respiratory rate for you?
Normal, sir. No tachycardia, no tachypnea.
Failure. So we are congestive cardiac failure, usually we have associated fibrin. Okay, next slide, please.
Shanabas, about the previous slide. The heart rate is useful because other possibility of a liver dysfunction and biliary, the obstetrics thing, you expect the rate to be on the lower side. So a little bit argument against that possibility is that definitely we are considering hemolytic problem. And there again, the other things also, as you rightly said, the regularity in the rhythm, the volume, and the radiofemoral delay all are important in this case. You just moved on without thinking. Maybe maybe you are consider this possibility. Regularity is important in this case. Radiofemoral delay part, maybe an adolescent girl child, there can be a hemolytic problem with a connective tissue disorder vasculitis situation. So that other pulses are important. The volume part usually expected with a pallor, but very short period pallor, a bit unusual. Acute hemolysis situation, the high volume argues that there was a little longer duration of this anemia. So you expect the high volume cardiomegaly and all when there is a little longer duration. The duration, it is helpful there. So it's not a very short, a little longer duration. The irregularity, because in this context of lepto, you need to consider the cardiac irregularity and all. So you have mentioned all these things, but these are all otherwise also relevant. Thank you. But
okay, so you should tell pulse rate than heart rate. Eh?
Okay, sir.
12 years. So you should go. Okay.
Okay, sir. BP, systolic was 110, diastolic was 70 mm of Hg in right upper arm in supine position. Saturation, oxygen saturation was 98% in room air, which was also normal.
Previous slide, there is a contradiction here because you mentioned the pulse volume is high. From your BP, it seems only 40. Cross check it always.
Okay, okay, sir. Head to foot examination, shape and size of head normal, no hemolytic facies, eyes, pallor and jaundice present, oral cavity, oral mucosa appears pale, no glossitis or angular stomatitis, no mucosal ulcers or gum bleeds, neck, no thyroid swellings, chest and abdomen appears normal, no abdominal distension, no scars or dilated veins.
Okay, hold on please. Hold on. Okay, so shape and head appears normal, so it is not a congenital hemolytic anemia. So okay, so what are the other things we look for in the eyes? Pallor is there, jaundice is there. For considering other possibilities.
KF ring for Wilson.
KF ring should be looked for. Then
retinopathy.
In which condition?
Sickle cell anemia.
Okay, then we look for cataract.
Yes,
okay.
sir. Wilson.
So yes, we can bit later. We can have even cataract also in a case of AF Wilson. We can have cataract also. Okay. So oral mucosa appears pale, no glossitis, anglosum. Okay. Okay. Why should you look for mucosal ulcer?
Sir, in SLE, oral ulcers, hard palate ulcers.
What is the peculiarity of hard palate ulcer in SLE? Characteristic feature.
Sir, it's a part of.
It's a painless ulcer. It's a vascular.
Painless ulcer and.
Okay. So chest and abdomen appears normal. Okay. Next slide. Okay.
No bone tenderness, no leg ulcers, no skin rashes or petechia or purpura, no koilonychia dactylitis. Sexual maturity rating stage 2.
Okay. Okay. So okay, can proceed.
Anthropometry, weight for age, observed was 30 kg, expected was 40 kg, at 10th centile of IAP growth chart, normal. Height for age, 144.5 centimeter, observed, expected was 148 centimeter, between 25 and 50th centile, which was also normal. BMI, 14.3 kilogram per meter square, expected was 17.4 kilogram per meter square, between 5 and 10th centile, which was also normal.
Okay. So growth is somewhat normal. Okay.
Yes, sir. Then I would like to examine GIT first.
Express
So,
the BMI, the previous slide. Is it a kilogram per meter square?
centimeter square, sir. Sorry, sir. No, it's meter square, sir. 14.3 kilogram per meter square.
Shanavas, our meter square no.
Usually we'll have PMI is a
BMI is such a
number.
per kilogram is not needed. Okay.
Okay, sir. GIT examination. Upper GIT, oral mucosa appears pale. No gum bleeds, no tonsillar enlargement or dental malocclusion. Inspection, shape of abdomen normal. Umbilicus central. All quadrants move equally with respiration. No dilated veins or scars. No visible pulsation or peristalsis or mass.
Okay, nothing is relevant. Nothing, no finding.
Palpation. Abdomen soft, non-tender, no localized area of warmth, no hepatosplenomegaly. Percussion, all quadrants appear resonant on percussion, no fluid thrill or shifting dullness. Liver span 9 cm. Auscultation, normal bowel sounds.
Okay, so no organomegaly. You didn't have any organomegaly. So
Yes, sir.
uneven. Okay. Abdominal finding.
Yes, sir. CVS examination, heart rate was 102 per minute. Blood pressure 110/70 mm of Hg. JVP not elevated. Inspection, precordium appears normal. No visible pulsations. Palpation, apex feet felt at 5th intercostal space, medial to midclavicular line. Auscultation, S1, S2 normal. No murmurs.
Okay. Nothing. Okay. Proceed.
Respiratory tract, inspection, symmetrical movements on both sides, no retractions or use of accessory muscles, both nipples at same level, no sinus, scars or chest wall deformities. Palpation, bilateral chest movements equal on all areas, no local rise of temperature, position of trachea midline.
Okay, proceed. Nothing.
Apex beat felt at the left intercostal space, medial to midclavicular line. Auscultation, air entry bilaterally equal, bilateral normal vesicular breath sounds heard. CNS, higher mental functions, appears and behavior normal, oriented to time, place and person, gait normal, speech normal. Cranial nerves, no focal neurological deficit. Motor cyst, bulk tone, power normal, no involuntary movements. Deep tendon reflexes normal, no neck stiffness, no meningeal signs. Sensory system within normal limits.
Okay, you have finished your examination.
Yes,
So you can summarize your finding in
Go back to the previous slides about the CVS findings and the liver span. The classical problem, this patient is a significant pallor. No doubt there is a pallor because all the other things point. And she didn't have blood transfusion. And we had a tachycardia, obvious tachycardia, 112 for a 12-year-old child, definitely significant tachycardia. There is nothing to account for the tachycardia. Fever is not there. So in such a patient with a tachycardia with, as you said, high volume pulse, we expect something in the cardiac. The patient tachycardia, our impression is that patient is already early congestive failure. Your liver span doesn't argue for that. And your cardiac enlargement is not there. You don't have a JVP raise. You don't have any murmurs. So, is there any, it's not all going together. A little bit odd thing. Tachycardia is definite, unexplained by any other thing. But there is nothing in the cardiac thing to account for that. Liver span doesn't argue for congestive failure. JVP is not raised, no murmurs, no cardiomegaly. So, how to explain that is question. Very short period anemia, you need not get a cardiomegaly because it's a compensatory thing. In that situation, tachycardia is the liver span is only 9, JVP is not raised. So, a little bit difficult to explain that part. Okay, anyway, you need to cross-check that findings. So when you are presenting a finding, but it's not fitting, contradicting statements, okay. Proceed, Shana sir.
Okay. Summarize your history plus examination and your differential diagnosis.
Examination parents, no pallor, no icterus, no splenomegaly. Summary.
So where you will get what is the importance of examination of parents? Very specifically look for.
Sir, in view of chronic hemolytic anemia, that is hereditary spherocytosis.
There is chronic hemolytic. You have got only 10 days history. Okay, you should
Yes,
you should examine, because as an examination you have to do, but your explanation is not like that.
Okay, sir.
So you have to look for all patients. You can have hereditary spherocytosis, can have this one. So it can be asymptomatic illness. That should be chronic illness. It should be asymptomatic.
Thalassemia minor.
Not thalassemia, hereditary spherocytosis. Thalassemia
Hereditary
minor.
spherocytosis.
Okay.
Summary. 12-year-old girl presented with history of acute onset of dark-colored urine, fever, tiredness, and yellowish discoloration of skin, with no past history of similar episodes or comorbidities or blood transfusions or significant family history, was found to have pallor and jaundice on examination.
Here you have to highlight, now your diagnosis is somewhat hemolytic anemia. So you have to tell, is there any history of drugs? So what is the importance of drug? What are the drugs that can produce hemolytic anemia? What are the ways drugs can produce hemolytic anemia?
So there are 3 ways. One is hapten adsorption, which is caused by penicillins and cephalosporins. Next mechanism is autoantibody formation by methyl dopa. The next one is immune complex formation by quinine.
Okay, so this so many drugs can. So you should tell there is no history of drug intake, no history of suggestive of any recent infection. There is a history of travel to. You said there is a history of travel to Kashmir.
1 month back, sir.
Okay, so is it will it affect your diagnosis in somehow? Can you tell something?
In view of viral hepatitis, leptospirosis, we can consider, but after all the summary, we
So it is very common. Kashmir, there is leptospirosis very common. Is it like that?
No, sir.
Then this way.
The food intake.
What is the temperature in Kashmir?
Cold temperatures.
So what will happen when there is an exposure to cold?
Cold hemoglobin.
Okay, in case of cold hemolytic anemia, cold hemoglobin, we can have an what is the mechanism? Just like tell what is the mechanism?
Mechanism of what,
there
sir?
There is an exposure. We can have there is sensitization with complementary.
Yeah, agglutination.
Comes to the warm climate, it can produce hemolysis.
Yes, sir.
Okay, that way you can examine. Or malaria, North Kerala, not Kerala, North India. So you can consider. In that way you can explain. So that is drugs. You can ask about drugs, travel. Then regarding infection, other infectious causes, malaria already you said. Then regarding you can tell regarding so this physical examination finding, you should tell whether there is splenomegaly present or not. So why, if there is splenomegaly, is there, what is your diagnosis? Not there, what is your diagnosis?
Splenomegaly is there. Hereditary spherocytosis, we can.
So can hereditary spherocytosis can produce us? You said it is a what is the color? What is the high color due to your patients?
The high colored urine. Later it was changed deep red color, sir.
What is the cause of high color urine for your patient, according to you? Is it due to jaundice, serum bilirubin, or due to hemoglobinuria, or like that?
Sir, initially it was due to high bilirubin, but later it was changed to hemoglobinuria.
So if it is hemoglobinuria, will you consider your diagnosis of hereditary spherocytosis? Will you consider hereditary spherocytosis?
But
where is the hemolysis? Where is the hemolysis? Where is the hemolysis in the hereditary?
No, sir. Hereditary spherocytosis, extravascular hemolysis has happened. Intravascular only hemoglobinuria present in intravascular hemolysis.
Okay, so it is unlikely to consider It is ferocity. You can consider other diagnosis. Where you can have intravascular hemolysis.
In intravascular, malaria is one of the differential.
Malaria.
Then Clostridium perfringens.
Can you consider Wilson?
Wilson also, yes, sir. Intravascular hemolysis.
Okay. So infection like Clostridium or other
Clostridium, malaria.
Malaria-like infections we can consider. Okay. So splenomegaly may suggest some infection, especially. So splenomegaly may or may not be there in case of autoimmune hemolytic anemia. Your diagnosis of autoimmune hemolytic anemia is not at all affected by spleen, but splenomegaly is affected by other causes, even infection and other causes. Okay. So you should highlight there is no splenomegaly. What type, which percentage of hemolytic anemia, autoimmune hemolytic anemia will have splenomegaly? What percentage? Around 20 to 30%, only around 20% or 30%. So organomegaly is not a not a manifestation or not a criteria for diagnosis. Okay. So you can answer. Okay. Then diagnose. Your diagnosis.
Sir, differential diagnosis, sir. First one is infection. Then is primary autoimmune hemolytic anemia. Secondary autoimmune hemolytic anemia due to SLE. Hematological malignancies like lymphoma, leukemia. Rarest differential diagnosis is paroxysmal nocturnal hemoglobinuria.
Okay, well, why do you consider infection as your first diagnosis? Which infection produces this much pallor, significant pallor plus hemoglobinuria?
Malaria.
Okay, you will consider falciparum malaria. So this type of falciparum malaria will produce hemolysis. So much hemolysis. So can it be an episodic malaria or a dose which is more commonly seen? What is a mechanism of hemolysis, intravascular hemolysis in case of malaria falciparum? What are the ways anemia?
Non-immune mediated hemolysis.
Okay, so usually it is a malarial parasite overgrowth itself can produce a problem, hyperparasitemia. That is a reason. Other reason is an immune mediator. So you can have immune mediated also, is rarely. Yes. Okay, both way you can have. But usually it is seen more commonly in endemic areas. So if a single visit will not produce an intravascular hemolysis this much usually. So you can consider your diagnosis as autoimmune hemolytic anemia higher in the list than infection. You bring down the autoimmune infection, second diagnosis.
Okay.
So why do you consider, what is the cause of fever in a case of autoimmune hemolytic anemia in that case?
Sir, autoantibodies.
So infection, sometimes it will be infection, mycoplasma infection, CMV, EBV, HIV. So like that, any infection can produce a fever plus autoimmune hemolytic anemia as a part of it. Okay, so in that case, you have to closely look for organomegaly and generalized lymphadenopathy and also other throat for patch like that. So you should highlight when you examine, you have to look for IMN by looking on the throat nodes, petrocular nodes. There is no generalized. You highlight those points so that you are in the history. You know, you are in the history only. So anyway, autoimmune any hemolytic anemia is more by investigation, so diagnosis by investigation than by okay. So primary autoimmune hemolytic anemia due to then secondary to SLE. Why do you highlight SLE as a possibility?
Sir, the age, adolescent age group, female sex.
Okay, females is the most important one you can consider. With the age group also, there is no other feature, but one of the manifestation is hemolytic anemia.
Yes, sir.
Due to positive or hemolytic anemia. Then hematological malignancy and lymphoma, leukemia. You have to have other evidences. Only by investigation we can say. Then paroxysmal nocturnal hemoglobinuria. Okay, why do you consider that later? Only you said last. Again,
very rare.
Only by investigation you can diagnose.
Yes, sir.
Sir, Purushottam sir, order of diagnosis is okay, sir? It's DD. Purushothaman Saranda.
Nothing more to add.
DD is okay, sir. Order. Infection she is highlighted the first, but I think he can directly go for autoimmune hemolytic anemia than infection.
Okay, sir.
Because okay. So how will you approach this side?
Among the drugs, rarely the Ayurvedic drugs also we should be considering. We'll be all considering modern medicine drugs. There are few people, they may not be telling about this disease and the drugs, but they may be taking continuously the Ayush preparations, which may be containing heavy metals, and few of these heavy metals can lead to all these hematological, liver, renal, all sort of things. Well, when you ask about the drug history, that point also to be kept in mind. That's all.
Just mention about indigenous drug. This has to be indigenous drug in the history.
Yes, sir.
Okay, so how are you going to proceed this side with?
Sir, first I would like to do complete blood count and CRP.
So what are things in the blood count? So your diagnosis of hemolytic anemia. For diagnosis of hemolytic anemia, what are the things you want to do?
Sir, I want to know the level of HB to grade the severity of anemia.
Okay.
Whether the patient is needed a blood transfusion or not.
Okay. So hemolytic anemia diagnosis, severity of anemia by hemoglobin. Then
Total count. Is there any associated infections or malignancy? And in leukopenia, in view of
when we plan and when we talk about the investigations, always start with the very basic, simple, cheap, non-invasive investigations to begin with. In this case, urine for microscopy, bile salt, bile pigment should be mentioned first, because you are considering the possibility of hemoglobinuria or RBC. That is one thing, it's very important. In a microscopy, if there is an RBC which is responsible for the drug color, the whole thing will change. That argues that there is a renal pathology. If no RBC, but the red color is there and you can demonstrate hemoglobin, that's proving that hemoglobinuria is there. So microscopy and bile salt, bile pigment also, that is important because most likely you are unconjugated hyperbilirubinemia. Then the very same thing when you're taking the blood, of course, all the other things, and include the plasma color of centrifugation, because in this case, you are suspecting intravascular hemolysis there also. That is a simple thing. So when you go for the blood, okay, counts and go forward.
Then differential count, neutrophilic leukocytosis in view of infection, like leptospirosis. Then lymph neutropenia in view of aplastic anemia or bone marrow infiltrations by leukemia.
So you are telling all investigations. You tell what are the essential investigations that you want to do.
So
HDR, serum bilirubin, total.
Yes, sir. Serum bilirubin
so
and
will show what?
Elevate indirect hyperbilirubinemia.
Indirect hyperbilirubinemia. You to confirm or to consider hemolytic anemia. What are other things you want to do?
Sir, serum LDH.
LDH will be elevated.
Elevated. Serum haplo.
SGOT. These are things that you can easily do in the lab. Haploglobin is a special investigation that you have to send.
Peripheral smear also.
Okay. So peripheral smear is another
evidence of hemolysis.
Reticose count. So reticount. So hemoglobin and PCV with reticount.
Yes, sir.
Okay. Then go for haploglobin if you want. You can do.
Then I want to
talk about the peripheral smear. Tell thick and thin peripheral smear.
Okay, thick for parasites, thin for morphology.
Thick and thin peripheral smear.
Sir, thick for parasites and thin for morphology RBC.
Okay, thin for species identification if malaria is concerned.
This identification also.
You do the other thing, hemolytic anemia, you do routine Leishman stain for confirmation of hemolysis. What are the peripheral smear abnormalities of hemolysis?
Sir, polychromasia, a nucleated RBC in the peripheral smear, and leukoerythroblastosis.
Where will you get leukoerythroblastic blood picture?
Sir,
Where
due
will you get
to
leukoerythroblastic?
increased amount of erythropoiesis in bone marrow.
Where will you get leukoerythroblastic blood picture? When there is some bone marrow infiltration by solid or other malignancies. So why should you go after those things? Okay. So you can have anisocytosis because we can have small normal cells and large cells. Then polychromasia because you are having
Polychromasia is there.
reticulocytes because that we have polychromasia. This is the most important thing you can have in case of the you are, even though you are, if it's a male child you are considering GCSPD, you should look for Haynes bodies and other and Haynes bodies and so what have you demonstrated Haynes body?
Pressure.
Okay, you should do for supervisor saying.
Supervisor saying. Brilliant.
You can do a present thing for.
Yes, sir.
Okay, so like that you can. So then, what is the next investigation? Most important.
Direct comb test.
DCT. Okay, you should look for DCT in case of it. So how will you different? How is it help DCT to differentiate between your two important diagnosis of autoimmune hemolytic anemia with warm antibody versus cold antibody? How will you help it?
Sir, if DCT is positive, warm antibody by IgG estimation, sir.
So it is done using at normal temperature and low temperature. So it's temperature wise it can DCT positive.
DCT positivity at IgG will be positive 37 degree in warm autoimmune hemolytic anemia. Sir.
So the other one you can demonstrate by
cold is at 4 degrees, sir. 4 degrees.
Okay. So that way you can do. So you have to find out the other causes, secondary causes of this one by suitable investigation. What are the other causes you should look for? Other causes of.
And was just one point. Okay. When you are answering Dr. Anwar's question, you're just going into trouble by adding one unnecessary point. Leukoerythroplastic blister, if you are talking, sometimes you may be in trouble. So always don't bring things unnecessarily and you will be in trouble to explain that. Okay.
Yes,
then about the cold agglutinin possibility, is there any bedside test possible?
Where will you get cold agglutinin positivity in which condition? Which infection?
Mycoplasma and EBV.
Okay, mycoplasma EBV. Okay. So in the case of
bedside test possible in the case of mycoplasma, you take a sample of blood heparinized and then you keep it in our refrigerator for some time. Heparinized blood will not clot. Okay, if there is a cold agglutinin, that will be clotting. And you can take another control sample from another patient. So any time at midnight also, you can check this thing from the bedside. The other things will come with their investigations.
Okay.
We can see by a hand microscope, handheld this magnifier, and look for the Rouleaux formation. The agglutination can be seen in by making the blood cold. And in what is the test for confirming or considering mycoplasma pneumonia?
Mycoplasma, IgM.
IgM mycoplasma and also IgM mycoplasma, IgM can be done, PCR can be done, and also for varicose are cold agglutinin can be assayed by serological dilution also. More than dash will give you a clue to it is a mycoplasma. How much? More than 1 in 64 dilution cold agglutinin positive.
More than 1 in 64 if cold agglutinin disease. More than titer is 1 in 64.
Okay, so you can go for other causes of hemolytic anemias in the form of
SLE. Secondary causes SLE.
DSD,
to rule out ANA. First we have to do ANA.
This is a specific test for SLE.
Yes, sir. Anti-double-stranded DNA and anti-Smith antibody.
It's not specific. DNA is specific for lupus nephritis.
ANA, yes, sir.
DNA is specific for, and dsDNA is specific for
lupus nephritis. Lupus nephritis. Lupus nephritis.
This is the specific one. And this method MCQ answer. Okay, so then you can go for Wilson. How will you roll out?
24-hour urinary copper excretion and serum ceruloplasmin.
Okay, serum ceruloplasmin and copper excretion what you can consider. Secondary causes like Wilson, then malaria. You already said fusion by. You can go for RD rapid diagnostic test of malaria or microscopy. Then mycoplasma pneumonia, EBV. So these types of those type of investigation you should consider. And when there is a hematological malignancy suspicion is there, you go for bone marrow and other investigations. Okay. Any other investigation left?
And this in this plasma centrifugation can be useful for hemoglobin intravascular hemolysis. Another thing is to estimate the hemoglobin more than 60. I think it's more than 60. Argues that it's an intravascular hemolysis. It's a useful test.
Yes.
Okay. Any other investigation that is left? So you already said haptoglobin, hemopexin, like investigations. Okay. So what is the role of hemopexin? What is the role of haptoglobin? In which condition it is low?
In hemolytic anemia, it will be low, sir. Serum haptoglobin will be low.
Okay, without anything. Okay, so it's an acute phase reactant. It is not always suggested. Low is not always needed. It is even if it is sometimes it may high. Hemopexin and haptoglobin, what is the difference?
Haptoglobin is a positive inflammatory mediator.
So both are used for hemoglobinuria, hemoglobinuria. So when there is a first thing that will come is haptoglobin. Once it's saturated, hemoglobin will be converted to methemoglobin, and there will be perihemosyne form that will be bind with hemopexin. Okay, and also finally albumin will be binding with this one. When albumin is also saturated, what will happen?
It will stay in the plasma, sir. It will be excreted through
urine. So the long-standing hemolysis indicates which urinary examination will you do? Which urinary examination will you do in a case of long-standing hemolysis?
Urine hemoglobin, sir.
Hemosiderin. So you should look for
urine hemosiderin, sir. After 1 week.
So you can stain with this Prussian blue or some special stain can be used. Okay, so these are the investigation. So how are you going to manage this stain? So after that, after investigation, what is your diagnosis finally? What's the diagnosis?
Primary autoimmune hemolytic anemia, sir.
Primary autoimmune hemolytic anemia due to IgG or IgG mediated or IgM mediated?
Sir, IgM mediated.
Okay, it's microplasma. That's the usual thing that is seen in case of in an adolescent. So what would have been the cause? What would have been the cause? Mycoplasma pneumonia. Could be a mycoplasma pneumonia.
Yeah, yes, sir. EBV and mycoplasma pneumonia.
Mycoplasma pneumonia is the most common because.
Or idiopathic also.
Okay, so that is okay. How are you going to manage this thing?
Sir, my first line of management is by using steroids, sir. But in case of cold type, steroids are not indicated. So I want to start. Sir, avoid first line management is avoid cold exposure, and it is a self-limiting illness, sir. So just wait and watch. If there is a severe hemolysis, if a child started developing symptoms of anemia, we can transfuse the least incompatible sample after minor blood group cross matching, and we can supplement folic acid. Then
one point.
rituximab we can give, sir. Rituximab.
Is she having the fever now?
No, sir.
No fever. Okay. As somebody was pointing out, we need to consider always a coexisting situation. Sometimes plasmodium need to be ruled out because plasmodium is very difficult to get in a peripheral smear. So even if the peripheral smear is negative, you can't totally rule out. Always go for the other recent test also. There may be questions regarding the other diagnostic test of malaria, the malaria vaccines and all. So we need to consider one of the eminently treatable entities like malaria always consider that. That's all.
Okay, sir. Sir, so drug-wise rituximab will be my choice.
Okay. So the main management will be depending on the supportive management. That is, you can have folic acid supplementation with exposure to cold, avoid exposure to cold. So a very young child and all, you should use, especially in cold environment, you should use cap, mitten, full sleeves like that, so that exposure to cold can be avoided. And severe hemolytic anemia, where there is severe anemia, is there transfusion. It's very difficult to have good cross matching. So you have to do the
Blood group, minor blood group incompatible.
Maximum
Least incompatible.
Least incompatible, but can be transfused with the close monitoring. So that is the most important. So there is no need, no role of steroids in case of cold hemolytic anemias, and also IVIGs. In either case, IVIG is not.
No.
So if it is a warm hemolytic anemia, what is your management?
Steroids, sir. My first line will be steroids.
What is which steroid will you give? How long will you give?
We can give us IV and oral. Oral prednisolone at the dose of 2 to 6 milligram per kg per day, or IV methylpred as 0.5 to 1 mg per kg per dose, 6 hourly for 3 days, or 30 mg per kg pulse doses for 3 days.
Okay, pulse dose. Even though we used to tell pulse, we used to give pulse dose. So it is not very much recommended in textbooks. So they are using the routine dose, 3 milligram, like that is on their advising. But we used to give pulse methylprednisolone. That will be very effective with blood transfusion. Alternative?
IVIG.
IVIG.
IVIG 2 gram per kg as 1 gram per kg for 2 days, or 0.5 mg per kg per day for 4 days.
What is the role of steroids? What is the mechanism of action of steroid?
It will decrease the complement mediated hemolysis and autoantibody formations.
So FC receptor mediated hemolysis is prevented. Okay, these are the two important management. And only second line. So previously we used to do splenectomy as the management of management, but nowadays splenectomy is
not that much indicated.
Not needed because of the. Okay, what are the indications for splenectomy? What are the prerequisites for splenectomy? Since we used to previously, we are used
vaccination. Should be vaccinated against meningococci, H influenza, pneumococci prior to splenectomy.
Okay, then.
Sir, penicillin prophylaxis should also be given before.
Minimum penicillin prophylaxis for minimum 1 year. Or, okay, minimum of 1 year should be given for penicillin prophylaxis. Okay, so through complications of splenectomy also in between you may be asked. Okay, so you can have thrombocytosis and other complications. Okay, so what are the investigation results of your patient? Somebody is asking. Somebody is very much interested in your patient's investigation result.
Okay, sir. These are the investigation results. HB was at 5.8 at the time of presentation. Total count 2,400. Neutrophil 67, lymphocyte 28, platelet 1.71 lakhs. PCV was.
What's the platelet for you?
Yes, sir.
What is the importance of thrombocytopenia? So platelet count for you.
In autoimmune hemolytic anemia, platelet can also be affected, sir.
This condition.
All
autoimmune.
PC, ITP, Ivan syndrome.
Answer has already come. Okay, so Ivan syndrome you can have associated autoimmune hemolytic anemia with ITP candidate. So nowadays, so they said that just like the ITP, autoimmune hemolytic anemia is somewhat similar to that in pathogenesis, management, and also the course is just like that of ITP. You can do what is it called? So the platelet count has come down on 62,000.
Yes.
Okay.
Yes, sir. We are suspecting associated sepsis at that point because the CRP shot up at that point.
Okay.
So that improved when we upgraded the antibiotics.
So your initial was mycoplasma. Okay.
So we treated for mycoplasma, and mycoplasma IgM was negative.
ECV was very low. Still it is low, 5.2 only. 10.6. Okay. Okay. So MCVs are usually in a case of acute hemolysis, normal MCV. Here it is very high, 110. Okay.
So,
Why MCH is high?
sir, it can be due to increased hematopoiesis, retic count, nucleated RBC, large size.
Microspherocytes shall have the MCHCs increase only one condition. Which is that condition?
MCVs,
MCHCs increase only one condition.
mycoplasma.
It is inherited spherocytosis. When there is spherocytosis, baby already answered. We don't inherit spherocytosis. So in case of hemolytic anemia also, there are a lot of microspherocytes that will be there. So it can be, that may be the reason where it is MCHC is high. So CRP was, okay, now last is increased. ESR is always on the high. Why ESR is high? Why ESR is high in case of autoimmune hemolytic anemia?
Sir, because of Role formation.
Increased Role because of the lot of RBCs. The RBCs are coated with immunoglobulin complement. There is an increased Role formation. Is there. So that's the reason why. Okay. Retic count, it is beginning, it was very high, 15%. RDW was. What is RDW in hemolytic anemia or any hemolytic anemia? Not autoimmune, any hemolytic anemia?
RDW will be normal, sir.
RDW will be elevated because you are having microcytes. You are having normal RBC spherocytes, and also you will have different shape. Indicate different shape also. Reticulocyte counts are counted. Also you can have elevated RDW. Here also it's on the higher side. Okay, urea was 76, creatinine normal. OT was mild elevation. PT normal. Alkaline phosphatase. Bilirubin was 3.6. Okay. Okay, these are the investigations. Any other investigation? Over.
Yes, sir.
And this previous slide on the previous slide. In this slide, when you write in the second column 2.5, see 35 to 6. Don't cause mistakes. The second column is 2.6. Then better to add any interventions also in the column. When you are presenting several days, over time a value is changing. So what was the intervention? Whether you have started a immunomodulator, steroid, IV gamma, rituximab, whatever you added can be included in the chart so that we can assess is it a response to that drug. So you can include any of these as a remark in the date wise. You can add that. Okay. Then it seems that the bilirubin, the last column, see the direct fraction on the last, it's on the 7th, a little on the higher side.
Yes,
again, as Dr. Rosemary said, the last part, there can be another reason also adding on to this thing, a sepsis may be there. So the direct bilirubin, among the 6.5, it is 3.7. All the other times, it is unconjugate only.
Yes,
so it's a little bit increase in the direct fraction, thrombocytopenia and all. So there must be another thing. When the MCV is consistently very high, it can be part of the younger generation of RBC coming out during the hemolysis, but always consider another thing, VTOL or something also is there contributing to this thing. That is a point to consider, because when you are not getting an expected response, you need to consider coexisting simple problems, treatable entities.
Yes, sir. We have done so.
Okay.
Next slide.
Proceed.
Okay.
Peripheral smear. RBC show mild degree of anisopoikilocytosis composed of normocytic, normochromic, and microcytic hypochromic picture. Many polychromatophilic cells, few elliptocytes, ovalocytes, and teardrop cells. WBC count is reduced. Neutrophil 68, lymphocyte 29, eosinophil 2, monocyte 1, occasional reactive lymphocyte seen. Platelet morphology is normal and counts are normal. Hematoparasites not seen. Impression, dimorphic anemia, normocytic normochromic to microcytic hypochromic and moderate leukopenia. Evidence of active erythropoiesis is present.
Okay, so okay. Any other investigation?
Serum studies we did. Serum iron was 40 microgram per deciliter. Serum ferritin 1480. Total iron binding capacity was 258. Transferrin saturation 18.06. Vitamin B12 level was more than 2000. So here serum iron was normal, sir, but towards the lower end. Serum ferritin is elevated. Total iron binding capacity somewhat normal. Transferrin saturation is low, sir. Vitamin B12 levels normal.
Okay.
Serum LDH was raised 1306. Urine hemoglobin detected. Urine routine examination and chest X-ray was normal. Dengue IgM was positive. Epstein-Barr virus IgM negative. Leptospira, Mycoplasma and scrub IgM was negative. Viral test negative. HIV, HBsAg and antibodies.
1 minute. When you are presenting two things, when you are presenting the peripheral smear, WBC count was on the lower side. In
Yes,
that
sir.
situation, there are two extremes of the case. Last part and your peripheral smear doesn't correlate. So you need to mention the peripheral smear taken on the earlier days or the later days. So it may be the peripheral smear represents the earlier days.
Yes, sir.
So the peripheral smear must be different from the last few days and the earlier days.
Earlier days.
Also, these results also are important. You are getting an unexplained thing, which does something which is not fitting with the autoimmune hemolytic anemia. Why, how to explain the serum ferritin, lot of findings. So
Yes,
can be explained by some other coexisting infection or something is there. So it's an acute phase reaction or macrophage activation. A lot of things you need to consider. In the peripheral smear, when you mention about the WBC, it's not a count only, whether there's a shift to right. So when you're considering a vitamin B12 in the early phases, so you need to consider the WBC morphology and the shift to right is a clue there. Okay, thank you.
Yes, sir. HIV, HBsAg and anti-HCV negative. Blood, urine and stool culture negative. Rapid malarial parasite test negative. Direct comb test was positive. Serum INA was equivocal. ANA panel we did was found to be negative. These are the antibodies included in ANA profile: anti-RNP and anti-smooth muscle, anti-SSASSB, anti-double-stranded DNA, anti-Jo1, anti-SCL70, anti-centromere B, anti-nucleosomes, anti-ribosomal P protein, anti-histones, all were negative.
Shanavas, about the Coombs test, whether I don't know, I have to read, whether there is a chance of a false negativity, something called prozone phenomena. Is there a need to do with a different control, different dilution and all? I need to read about that.
So regarding Coombs test, by usually it is done by initially by polyclonal anti-IgG antibody. So it is a generic test. Once it becomes positive, you have to do specific for complement and also for this Donat-Landsteiner, the antibody.
Yes,
that's 4 degrees centigrade and then also at 37 degrees centigrade. That is for cold hemolytic anemia. So there is a very high chance of, well, not very high chance, there is a chance that there can be false positive also. False positive and false negative is also there. Both are described in the text.
Okay, sir. Bone marrow study. Bone marrow aspirate smear shows adequate cellular spicules. Erythroid series increased. Majority exhibit normoblastic activity. No dyserythropoietic features. Myeloid cells, orderly maturation. Myeloid erythroid ratio is reversed. No increase in plasma or plasma cells. Megakaryocytes normal in number or morphology. All are active. Bone marrow aspirate. Marrow is cellular. Myeloid cells are normal. No evidence of granuloma or malignancy.
Okay. So after your diagnosis, you got dengue positive.
Yes, sir.
Can dengue produce autoimmune hemolytic anemia?
It's rarely it can produce, sir.
All viral infection, any viral infection.
Or it can be false positive also, sir, due to some.
Not it's very co-infection, not false positive. Maybe because the count is also TC is also on the lower side.
Yes, sir.
So it can be a co-infection both. So dengue is all viral infections are very well known for to develop autoimmune hemolytic anemia. So dengue is also can be positive.
Yes.
Hepatitis A, B, C, like that, all infection can produce. Okay. So how is the patient? How is your patient now?
Sir,
Sir, actually,
Okay, doctor.
go ahead, Reza.
We transfused blood, sir. After that, in view of persistent fever spikes and ongoing hemolysis, we referred the patient to Vellore for stem cell transplantation and further management.
Okay.
Sir, actually, we tried everything, sir. We tried the IVIG, we tried methylprednisolone, rituximab, everything, but the HB was going on falling. So finally, the last day we started having fall in the second line also. So then we probably thought that it is something more than autoimmune, and we gave them a referral option to a higher center which has available bone marrow and all. So then they chose to go to Vellore. So that's how we sent them to Vellore. But apparently there also it seems to be autoimmune hemolytic anemia only. So it's going on in that way only.
Okay, so this cold is are usually self-limiting, but warm antibody can persist for months with early transfusion and other supportive management is needed. So the
Yes, sir.
one that usually seen in pediatrics that is called usually self-limiting, but yes,
Yes, sir, but this was severe anemia, sir. It was falling to 2s and 3s. It was very, and we were not getting blood also. It was a nightmare.
just like that 2 gram was our on the Alapura last year. There was a patient with 2 gram hemoglobin, that to 2-year-old child.
Okay.
Same thing we are
So
suspecting.
does it? So like we go on with the symptomatic management. We go on giving blood transfusions. Is that how we'll wait?
Yeah, that's right. That's how we should have some supportive management only. They're also doing the same thing, isn't it? CMC.
Yes. They also do.
Usually, it will be self-limited, but it will take some 6 months, 6 months, 8 months like that. So most of our patients used to respond to methylprednisolone or methylprednisolone like that, but it's usually warm. Cold, I think I had 2-3 patients. It was not much problem. It was within 2-3 months they were over after transfusion. Sir.
That was an excellent case, very interesting. I would like to know the follow-up, Dr. Rosemary, and wonderful, interesting case. Thank you for the whole team, Metropolitan. And also, ഇതാണ് ഇപ്പം convocation ആണ് ഞാൻ എന്നെ എക്സ്പെക്ട് ചെയ്യുന്നുണ്ട് അവിടെ അതുകൊണ്ടാണ് പോകുന്നത്. ഓക്കെ, താങ്ക് യു.
Okay, thank you. So thank you, Dr.
Thank you, sir.
And also the presenter who has presented very well, who has answered almost all questions very well. And okay, thank you very much. Praveen, over to Praveen.
Thank you, sir.
Thank you, sir. Thank you so much.
I think Praveen sir has some other meeting, sir, so he has left. He has to attend another meeting.
Okay. Thank you.
So we can wrap up now, sir.
Okay, thank you.
Thank you for giving us this opportunity to present. Thank you, Joe sir, for giving us this opportunity to present. And we are happy to be part of the PG Club. Thank you all.